Here's a case study scenario that involves a cranial nerve assessment following a head injury. Case study: head injury and cranial nerve assessment. Patient information: name, John Doe. Age, 28 years old. Gender, male. Occupation, construction worker. Medical history: no significant medical history. No known allergies. Current medications: none. Presenting complaint: head injury following a fall from a height at work. Background: John was involved in a workplace accident earlier today while working on a construction site. He fell from a height of approximately 10 feet, landing on his back and hitting his head on the ground. He was immediately assessed at the scene by a paramedic, who noted that he was conscious but appeared dazed. He was transported to the hospital for further evaluation. Initial assessment: upon arrival at the hospital, John is alert and oriented but reports feeling lightheaded, with mild confusion. He denies loss of consciousness but reports mild headache and dizziness. No obvious visible signs of trauma to the scalp or face are noted. Clinical examination: the initial physical examination reveals no external wounds or contusions. His vital signs are stable, with a blood pressure of 130/85 of a millimeter of mercury, heart rate of 72 bpm, and respiratory rate of 16 breaths per minute. The neurologic examination is the next step in the assessment, particularly focusing on cranial nerve function, given the head trauma. Cranial nerve assessment. Cranial nerve. Eye, olfactory, smell, test. The patient is asked to close his eyes and sniff a familiar scent. Vanilla. Findings: John reports that he cannot smell anything in either nostril and states that he has felt a partial loss of smell since the fall. Impression: likely damage to olfactory nerve, cranial nerve eye, due to head trauma, possibly affecting the sense of smell. Cranial nerve 2. Optic, vision, test. The patient's visual acuity is tested by asking him to cover one eye at a time and read an eye chart, Snellen chart. Findings: visual acuity is 20/20 in both eyes. Visual fields are intact as tested by confrontation. Pupillary response: a direct and consensual response to light is observed in both eyes. Impression: no signs of optic nerve damage or visual field defects. Cranial nerves 3, IV, VI, oculomotor, trochlea, and abducens, eye movements, test. The patient is asked to follow a finger through 6 cardinal fields of gaze. Findings: there is no ptosis, and eye movements are smooth. The patient denies any diplopia, double vision. Impression: no abnormalities noted in eye movement or pupil reactions. Cranial nerve V. Trigeminal, facial sensation and chewing test. Lightly touch the patient's forehead, cheeks, and chin on both sides while he closes his eyes to test sensation. Findings: the patient reports decreased sensation on the left side of his face, particularly around the cheek area. There is no difficulty chewing. Impression: possible injury to the left trigeminal nerve, affecting sensation, possibly due to trauma. Cranial nerve 7. Facial movements, test. The patient is asked to raise both eyebrows, close both eyes tightly, smile, and puff out both cheeks. Findings: the left side of his face appears slightly weaker compared to the right side when he smiles, and he has some difficulty puffing out his left cheek. Impression: likely damage to the left facial nerve, cranial nerve 7, possibly from the impact during the fall. Cranial nerve 8, vestibulocochlear. Hearing and balance test. The patient is asked to close his eyes, and the examiner whispers a number in each ear. Findings. The patient hears equally in both ears. Balance. No signs of vertigo or unsteadiness when the patient stands and walks. Impression. Normal hearing and balance. Function. Cranial nerves IX and X, glossopharyngeal and vagus, palate elevation and gag. Reflex test. The patient is asked to say, ah, while the examiner observes the movement of the uvula. Findings. The uvula rises symmetrically in the midline. Gag reflex. The patient has a normal gag reflex on both sides. Impression. No abnormalities noted in the gag reflex or uvula movement. Cranial nerve 11. Accessory, shoulder shrug, and head turn. Test. The patient is asked to shrug both shoulders against resistance and turn his head from side to side. Findings. The patient has equal strength in both shoulders and can turn his head with equal strength on both sides. Impression. Normal function of the accessory nerve. Cranial nerve 12. Hypoglossal, tongue movements. Test. The patient is asked to stick out his tongue and move it from side to side. Findings. There is no atrophy, fasciculations, or weakness noted in the tongue. Impression. Normal function of the hypoglossal nerve. Summary and plan. John's cranial nerve examination reveals some abnormalities consistent with potential nerve damage resulting from the head injury. Specifically, cranial nerve I, olfactory, loss of smell on both sides, suggesting olfactory nerve involvement. Cranial nerve V, trigeminal, decreased sensation on the left side of the face, indicating possible trigeminal nerve involvement. Cranial nerve 7, facial, mild facial weakness on the left side, likely affecting the facial nerve. Next steps. Imaging. A CT scan of the head should be performed to evaluate for any structural damage, such as fractures or contusions, that may be affecting cranial nerves. Follow-up. John will need to follow up with a neurologist if there are any significant deficits found on imaging or if symptoms persist. Referral. Consider a referral to a neurologist or otolaryngologist, ENT specialist, for further evaluation of cranial nerve function and management. Observation. Given the head trauma and possible nerve involvement, John should be observed for any worsening symptoms or new neurological signs in the next 24 to 48 hours. This case study provides an example of how a cranial nerve assessment might look in the setting of a head injury. It incorporates both the assessment process and the clinical findings that would guide treatment decisions.